So my name is Sherif Emil. I'm a pediatric surgeon at the Harvey E. Beardmore Division of Pediatric Surgery here at the Montreal Children's Hospital. I also hold the Mirella and Lino Saputo Foundation Chair at McGill University. That's a chair centered on surgical education and patient-centered care. And a lot of the research projects I do are within the mandate of that chair. And I am an investigator at the Research Institute as well. So I have a research in a number of different clinical areas, but I wanted to spend a few minutes featuring the work we've been doing on pediatric appendicitis in children. Appendicitis is the most common acute surgical condition in children and the most common condition requiring admission to a hospital acutely, emergently in children. And the volume here, the children's, has always been quite large. We do somewhere around 350 surgeries a year. So that number is larger than many of the emergencies in multiple other divisions combined, just to give you an idea of the volume. Our group here for the last 35 years, our very first major publication came out in 1990, long before I came here. And really, we have been interested in taking a disease that had been treated well in terms of having good outcomes, but still had a very significant burden on the patient and the family. Long hospital stay, very invasive procedures, lots of school time being missed, parents having to stay at home to take care of children, so on. And we have really, for the last 3.5 decades, been looking at how can we make this disease be associated with faster recoveries and return to normal. I'm not going to go through 35 years of research because that would be too long, but I would like to concentrate on 3 areas we've worked on in the last 5 years. So appendicitis has often been and continues to be described in most research papers and publications, presentations as a binary disease. Simple, meaning appendix is just inflamed with very little profile for risk. In other words, most of these patients do very well, to perforated, where there's suddenly pus outside the appendix, and that can render the patient quite ill with peritonitis, etc. And in 2018, we published our first paper really arguing that that should not be used, that the appendix is not a binary condition. It is a continuum. It is a stage type of disease, from simple appendicitis inflammation to early perforation, where there's just the beginning of contamination, to a walled off collection of pus, we call an abscess, to generalized peritonitis, essentially pus throughout the abdominal cavity, to both an abscess and generalized peritonitis. And in the only prospective study that had ever been done on this subject, we showed that, in fact, what we defined as what we call a grade of appendicitis correlates very strongly, not just with how the patient will do, what type of complications they might have, but also with the resource utilization, the operating room time, the number of days in the hospital, the number of days needing antibiotics, the number of days needing narcotic analgesia, etc. So that was a landmark study that really changed practice for us in a very dramatic way. For example, within our practice, we no longer talk about simple versus perforated. We always talk about the grade. That's how we communicate with each other. And that has transformed many practices as well, who know of our results and share the importance of the findings. We've taken this now one step further to define something called a PAG, P-A-G, or a Pediatric Appendicitis Grade. This was done through a consortium that I founded back in 2018 called CANCOR, or the Canadian Consortium for Research in Pediatric Surgery. So this included all of the pediatric surgical centers in Canada, 18 of them, and we took what we had published from here at the Children's and morphed it into a grade that includes all of appendicitis, not just the perforation. And we defined a PAG to go from 1 to 5. We just completed a study that should be coming out in the next few days in Annals of Surgery Open, so a very high-profile journal, where we wanted to show that the PAG is valid. In other words, if I do a laparoscopic appendectomy for a patient with appendicitis, and my partner does the same, and somebody across the city does the same, somebody in the US or somebody across the world, that we will rate the disease similarly, because that's very important. If there's no agreement on how the disease is rated, then we cannot advance the validity of the rating or of the staging scheme. So we included hundreds of participants from all 6 continents, all of the CanCore group, which is 16 centers here in Canada, 5 or 6 centers in the US, a center in Brazil, center in the UK, a center in the Netherlands, 2 centers in Egypt, 1 center in the Philippines, and 1 center in New Zealand. And what we did is we videotaped the surgery because we do it all by laparoscopy, and then we edited it and we placed it on a platform where the participants would look at the edited video and then rate it. And we studied using something called the intercorrelation coefficient to see, is there actually agreement? And we showed a extremely high level of agreement between participants, regardless of whether they were trainees or practicing surgeons, regardless of what country they were in, and regardless of how many appendectomies they did. So it was a very, very strong validation of the PAG, and that's coming out very soon, like within the next few days. And we created around that a video to explain to other surgeons around the world how to use the PAG and how to use it to grade it and what is the utility of it. And the utility is that we can now benchmark our outcomes. So we don't just say simple and perforated. We say this is a generalized peritonitis, and for example, you should not have more than a 5% chance of getting an abscess. So if your outcomes are worse, you can benchmark them. Also, very important of how we speak to families about it, because we can now leave the operating room and tell a family, your child has a PAG 3. We expect that child to be in the hospital for 4 days. We expect the chance that there's going to be another procedure to be, 1%. It's been incredible being able to actually counsel families regarding expectations rather than just give them a general idea. Also, how we look at research publications and make sure we're comparing apples to apples and not apples to oranges. And then very importantly, we are in a period in Canada and really throughout the world where we have to rate the burden of how we treat the disease, so that compensation that comes, whether it's for insurance companies or from the government or whatever healthcare system you're in, that hospitals are reimbursed appropriately, because not every appendicitis requires the same level of care. So this has been a huge transformation and a big practice change in the way we treat appendicitis. 2 other smaller projects related to the same is we performed the first study asking families and children who have appendicitis to actually document their input into the medical chart. The medical chart has an area for doctors, for nurses, for pharmacists, for nutritionists, but there's never been an area for parents. So this was a pilot study. We just completed it. We're going to be presenting it next month. That's really the first of its kind, to have the patient actually participate in the evaluation of their care on a daily basis. This is not like a satisfaction survey you administer when the patient's going home or 2 weeks afterwards. And that was really fascinating. We looked both at the patient experience and experience of the healthcare workers. And that was part of a master study that Dr. Josie Cipolla, my graduate student, is completing. And the last thing is we worked with an international group from multiple countries through the Enhanced Recovery After Surgery Society to create the first enhanced recovery guidelines for appendicitis. So we looked at thousands of papers that have been published over 10 years, sometimes going back 20 years, and really extracted the best evidence for what every step of the treatment is to look like. And we're just submitting this to JAMA Network Open, another very high visibility publication. And we really believe that this ERAS Society guideline for appendicitis, once again, will change care in a very significant way for patients around the world. So I'm very excited about this because, again, this is the most common acute surgical problem in children by far. Billions of dollars spent on care. And I think there's a benefit for the patient in improving their care, improving their recovery, but also a significant benefit for the healthcare system and our society as a whole by trying to be more cost effective in treating this disease.